Okay, so our numbers are picking up now. What I will do is we will get started immediately because I'm sure you're very interested in the content of the webinar this evening, and I'm sure you might have some questions for our presenters as well. So the title of the webinar this evening is Paxlovid for the treatment of COVID-19, the place in therapy, safety considerations, and management of drug interactions. So as you can see from the title, the intent of this webinar this evening has quite a clinical or a therapeutic focus. And so please bear that in mind as you listen to the content and with your questions as you follow up after the speakers deliver their content. So we won't be focusing on the administrative aspect of this medication, but there will be information issued on that in due course. So just in relation to the domestics, as I'm sure many of you are familiar with attending our webinars already, we ask that you have your microphones muted. You can have your cameras switched on or switched off. And as I mentioned already, this is being recorded and will be posted to the IAOP website after the event. There is a chat box if you hover over your screen, just to the bottom of your screen, and we are anticipating some questions this evening. The best way to manage that perhaps might be to hold those questions till the end, unless it's something you really want to confirm as we work through, but it might be easier to manage questions if we hold them to the end. So to allow me to introduce our speakers this evening. So we have Muriel Pate, who's Medication Safety Specialist Pharmacist for the HSE. Quality and Patient Safety Directorate, and Mary Philbin, Chief 1 Antimicrobial Pharmacist with the National Antimicrobial Resistance and Infection Control Team with the HSE. So Muriel and Mary are subject experts on this topic, and we're delighted to have them here this evening to talk through this new medication. So I will hand over to Mary and Muriel now, who will take over. Thank you.
Sharing my screen.
Thank you.
Okay, is that
that's
showing
perfect.
okay?
Yeah, thank you.
Okay. Thank you, Mary Claire. Good evening, everybody, and you're very welcome to this session, and I'm sure you're all very interested to hear about this drug, considering that it's in the country now, and I guess the administrative pieces are being worked through. So as Mary Claire said in the introduction, myself and Muriel are going to focus on the clinical aspects of the drug. We will define the place in therapy currently in accordance with the HSE interim guidance. We will include information on the dosing and administration aspects, following on with the safety considerations, and obviously, as I'm sure you're all familiar with, the drug interactions piece with this medication. And we will wrap it up then by going through 6 case studies to, I suppose, clarify really the place in therapy, highlight examples that will be applicable to your day-to-day practice, and the management of potential drug interactions. So in terms of its place in therapy, it's indicated for the treatment of COVID-19 in adults who do not require supplemental oxygen and who are at increased risk of progressing to severe COVID. So this infographic is taken from the HSE interim guidance for the pharmacological management of patients with COVID-19, and that's the version 4.1 of the guidance, which is available online currently. And you can see here, I think my arrow is hovering over it, that the Paxlovid very much has a role in the community setting, and potentially in some hospitalized patients where they don't have that oxygen requirement. And as I said, that infographic is taken from the interim guidance if you want to look at it in more detail. The mechanism of action of Paxlovid. So Paxlovid is a combination of 2 drugs, nirmatrelvir and ritonavir. Nirmatrelvir is the active component, and that is a protease inhibitor. And then ritonavir's function is to increase the plasma levels of nirmatrelvir for its activity. So we've included the link to the SPC here, and just to say that the European Medicines Agency has authorized this medication under a conditional approval scheme. So that means that there is further evidence on this medicinal product awaited. So again, the status of that may change.
And Mari, I think it's just helpful to say in terms of the conditional approval, you know, it just highlights or just makes it more important than ever to be thinking about the fact that, you know, maybe hasn't had the full rigor of some other medicines in terms of its coming to market now. So the HPRA link to report any adverse reactions is particularly important for as such a new drug.
Thanks, Muriel. Absolutely. That's a really important point to add at this point. And following on nicely to that is just highlighting the single study that has resulted in this conditional approval. It's the EPIC-HR study. So there were 2,000 odd patients included in this, approximately 1,000 in the Paxlovid arm and then 1,000 in the placebo. And it showed that there was a reduction in the hospitalization or death from any cause in the Paxlovid group in comparison to the placebo. Again, but I think it's very important to state that this, you know, these are relatively low numbers that we're dealing with. And moving on then to the HSE interim guidance to share with you where Paxlovid has been indicated. Again, this medication, there will be a limited supply, so it very much needs to be prioritized to those patients that are going to get the most benefit from this medication. The EPIC-HR study was carried out in an unvaccinated population, so that's where the greatest benefit in terms of the data that we know at this point. So obviously that is included in the interim guidance. So it's that unvaccinated adult patient at risk of progression to severe COVID, not requiring supplemental oxygen. And it's there, those patients are defined as tier 1 and tier 2, and we'll cover that in a later slide. And then also for those patients that may not have had an adequate response to their immunization, or in terms if they experience the disease that they may not have that adequate immune response. So it's a 5-day course recommended to be started within 5 days of symptom onset with a confirmed diagnosis of COVID by PCR or another high specificity method approved by a hospital laboratory director. So at this point, it's timely to define what is a vaccinated or an unvaccinated patient. So for the purposes of the guidance, the unvaccinated patient is defined as those who've received their COVID, who have not commenced or their vaccination schedule is incomplete. In terms of
yeah, sorry.
Yes, Muriel, yeah, great, come on.
Yeah, no, I suppose it's just important here to note that this might be a different definition from some other definitions of what it means to be fully vaccinated. So, you know, it's the primary course, which is the most important one that they're really talking about here.
Thanks, Muriel, for clarifying that. Yeah, so absolutely. So it's regardless of whether they've had their booster dose or not. And again, I think, Muriel, you'll agree it's important at this point to clarify or suppose to raise the point that really the vaccines are superior to the current treatments that we have available. So they very much should not be seen as alternatives to vaccination. And again, look, we'll see how the evidence base develops, but that's the position currently. So again, as I said, detailing those eligible patient groups a little bit further. So your tier 1 patients are those immunocompromised adult patients not expected to mount an adequate immune response to vaccination or to the infection due to their underlying conditions. regardless of their vaccination status. And those immunosuppressed adult patients who've had rituximab in the last 12 months or other B-cell or T-cell depleting therapies, or high-dose steroids. And those high-dose steroids are defined as patients receiving over 40 milligrams of prednisolone or the equivalent a day for more than a week, or more than 20 milligrams a day for 2 weeks in the last 3 months. The tier 1 unvaccinated patients are those all adults over 75 that are unvaccinated, or those unvaccinated that are over the age of 55 years with additional risk factors. And again, those additional risk factors are detailed in the guidance, but an example are those with hypertension or obesity with a BMI greater than 35. And your tier 2 patients are those unvaccinated adult patients at risk of severe disease not included in tier 1, and they're any adult over the age of 65 or adults under the age of 55 with additional risk factors. Again, I suppose there's a lot of information to take in that slide, but to say that it is all in the interim guidance, and that the link is available there for your information.
Yeah, and I think it's probably helpful just for people, or maybe a little bit reassuring, that, you know, there's no expectation that community pharmacies are going to be policing who's eligible and not eligible. You know, it's certainly possible that, you know, you may get queries from patients and maybe raising awareness about these medications with your patients, but it's not that you're going to have to, you know, work your way down through the eligibility criteria for every script that comes your way. That's not an expectation.
Yeah, Muriel, and yeah, it's important to have the awareness of that if patients ask you if you think they would be an eligible patient for this medication.
Yeah.
In terms of the dosing information, so you'll see the image there is what the individual daily blisters look like. So you've got your morning dose, 3 tablets for the morning dose and 3 tablets for the evening dose, and that's split up into 2 nirmatrelvir, which on the blister is referred to as PF 07321332. So 2 of those tablets and 1 ritonavir, 100 milligrams. So the dosing information is that there's 3 tablets taken together in the morning and in the evening, and again, ideally spaced 12 hours apart. And that's a 5-day treatment course. So there is a requirement to reduce the dose if the patient has renal impairment, and that's for those with a GFR of between 30 and 60. If they have a GFR less than 30, then it's contraindicated. And the dose reduction is a reduction from 2 nirmatrelvir to 1 twice a day. So there will be a requirement, and there's no change to the ritonavir dosing. So there will be a requirement at the dispensing point to remove 1 nirmatrelvir tablet from the morning dose and 1 nirmatrelvir tablet from the evening dose in all of the daily blister packs. Okay, so you'll be removing 10 tablets. Okay. And then in terms of timing of administration or other aspects to consider, it can be taken with or without food. It needs to be swallowed whole and not chewed, broken or crushed. So it's very important to call out at this point that if you have a patient with difficulty swallowing or an enteral feeding tube, and they would get their normal medication via that route, then these patients are not a candidate for this medication at this point in time. If a patient misses a dose within 8 hours, then it's fine to take it as soon as they remember within that 8 hours. But if the missed dose is longer than 8 hours, then the patient shouldn't take the dose and just wait until the next dose. In terms of adverse effects, these are the most common that are reported in the SMPC. So a difference in taste, so it can be a change in taste, that things are all possibly tasting metallic. Is one example. Diarrhea in 3% of cases, and headache in just over 1% of patients. So Muriel, I'm going to hand over to you now as we come on to the safety considerations and drug interactions.
Great, thanks, Muriel. So yeah, we might move on to the next slide. So I suppose, you know, you're all on here to hear about Paxlovid, so I'm sure most of you are aware that there are a significant number of drug interactions with this particular drug, and that's mainly due to the ritonavir component. So we know that ritonavir was previously, or still is, used as part of HIV therapy. So there is quite a lot of information which has been kind of built on to inform us in terms of what the drug interaction profile will be. And obviously we have, I suppose, the key information sources that are going to be most useful to you. Obviously there's the SBC and the link is there for that. But there's another resource which we're going to run through here and in the case studies, because it's a really useful resource which has evolved from work that the University of Liverpool have done with HIV meds over the years, but they've updated their website to include COVID-19 drug interactions, and they have updated it with all the relevant interactions for Paxlovid, which is really helpful to people who can access that freely. So the link for the Liverpool Drug Interaction Checker is on the slide there, and you can enter a number of medicines for any individual patient on that. And then also from the website, there is a PDF available, and that's the image which is shown on the right-hand side there. And that's, I suppose, a quick reference guide. So it is something that might be useful to print out and have handy as a quick reference. There's a lot more information on each of the drugs if you do go into the website and check the details for each drug.
And also, Muriel, just to let people know that it's available as an app as well, which is very handy to use on your smartphone as well. And to, I suppose, emphasize the usefulness of this interaction checker, really provides really on-point practical information that is what you require at the point of dispensing. So it will recommend a particular drug if it's suggesting to hold it for X number of days, say in terms of a statin. It'll say to hold it for 8 days or whatever. So it really is a really practical resource. Yeah. So definitely we would be advocating that you would consider it as your routine check when you're going through these medications.
Yeah, I certainly found when looking at the information from the Liverpool Checker that it's much more kind of this is what you need to do, whereas the SBC, while obviously it's comprehensive and it's useful, it doesn't necessarily give you such specific guidance on the steps that you should take. And then the other thing actually, which I didn't mention there, was that Pfizer do have a website checker available now, which has just recently been updated for the EU. So I think there's a QR code on the packaging that people can also access that. It's the same information that's in the SBC though. Okay, so in terms of drug interactions, so the main reason for all the drug interactions is due to ritonavir, which is a CYP3A inhibitor, and then nirmatrelvir is a substrate of CYP3A. So it's just really important to note that interactions with other drugs can lead to really clinically significant reactions, and they do include potentially life-threatening or fatal reactions. They can also include a loss of therapeutic effect of Paxlovid, and there's a possibility of development of viral resistance to Paxlovid as well. So it's really, really important to carefully check all concomitant meds before and during treatment. So to be, I suppose, alert to the possibility of adverse drug reactions associated with any other concomitant medicine. And just, I suppose, to bear in mind as well that Paxlovid shouldn't necessarily be started immediately after stopping certain contraindicated medicines, particularly those with a very long half-life. So that's just something to kind of bear in mind as well. And then one very important interaction just to be particularly alert to is that it may reduce the efficacy of combined oral contraception. So anyone who uses combined oral contraception should be advised to use an alternative method or additional barrier method while they're being treated with Paxlovid, and then also for a full menstrual cycle after stopping treatment. So just in terms of the steps that need to be taken, obviously with the drug with such, I suppose, the importance of the drug interactions with this drug, there is a real need for a careful medication history check. So obviously you need to know what all the currently prescribed medicines that the patient is taking, and most of those will be available to you if the patient regularly comes to one particular pharmacy. But there is a real need to just really confirm with the patient whether they get any prescriptions from any other prescribers or whether they attend any other pharmacies. And to check with them if they take any OTC or herbal medicines, because some of those do have significant drug interactions with Paxlovid. And then just, I suppose, to check that they aren't getting medicines from any other locations. So, you know, some of the mental health services sometimes administer meds, any inpatient or outpatient hospital meds, including, say, intermittent IV treatments, or that they're, you know, to check if there are any clinical trials or early access schemes. And just also to bear in mind illicit drugs, and particularly noting that, you know, there are interactions with sleeping tablets with Paxlovid. So GPs and prescribers are being encouraged to liaise with community pharmacy at an early stage. So I suppose it remains to be seen, you know, exactly how things will work in practice. But it's, I suppose it's envisaged that a lot of the time you will know about a prescription for Paxlovid before it comes, you know, in the door. And then, so there's a delay there may be a delay in terms of waiting for a PCR result for the patient. And then I suppose the other point is that the pharmacy can only order Paxlovid once the prescription has been received. So there's a couple of points in time where there will be a delay before the patient will be dispensed Paxlovid. And in some ways that's quite useful, because it just does allow you to have, you know, a pause to make sure you have time to assure yourself that all the checks, you know, have been made, that it is safe for Paxlovid to be dispensed for this particular person. If GPs are putting in a query to the NMIC, they're being asked to CC the nominated pharmacy on any of those requests, so that that information would be available to the pharmacy as well. And then the other piece is about renal function. So, you know, asking yourself if the patient is known to have renal impairment. That's not necessarily something that's always going to be known in a community pharmacy setting, unless the patient is on medicines for that, or they're able to tell you that they do have renal impairment. So again, it's not something that we necessarily would expect community pharmacies to go finding out what the patient's renal function is. That's not an expectation. But obviously, because of that possible reduction in the dose, if somebody has a degree of renal impairment, you do need to be familiar with what that means in practice in terms of advising the patient about the dose that needs to be taken and removing those additional tablets if they are on that reduced renal dose.
And Muriel, just to come in on that, there's, you know, it definitely is a point to highlight, is that communication piece with the patient, because again, the patient isn't going to be coming to collect these medications, this medication if they're obviously COVID positive. So it's making sure that that information is either directly communicated to the patient via phone, or if you're confident that the person collecting the medication will relay that, because again, could be quite confusing for patients opening their box of medication and seeing tablets missing from the blister.
Yeah, I think that applies, you know, even if they're on the standard dose, it's not necessarily all that straightforward a medicine. So, you know, I think it will be one that does need careful communication, most likely directly over the phone if that's an option that's available. Okay, so this is a flow chart which is included in the HSE guidance, and it's also taken from the University of Liverpool website. So on the left-hand side, it just runs through the contraindications. So it's not a drug that's licensed for pediatric use. So adults only, and then it's not recommended for use in pregnancy either. And then severe renal impairment, severe liver disease, or contraindications. The patient does need to be able to swallow tablets. And then once you've checked off those, it's a case of checking through any interactions for the patient. So I suppose that middle red box is just what we had on the previous slide about making sure that you're considering all medicines that a person may be taking from different sources.
And Muriel, just to clarify on that local age restrictions, just to let people know that this is an internationally used reference source. The States very much hold it in high regard, and it's referenced in a lot of their key websites. And I think the US are possibly using Paxlovid down to lower age groups, potentially 12. Don't directly quote me on that, but just to explain that's what that means in terms of check local age restrictions. So it's very much for that international usage, but for here it's for those that are 18 and older.
Yeah, and that may change over time as more evidence comes through. Yeah. Okay, and then just moving down that middle section there to where the amber box is. So I suppose it's a case of checking each of the other medicines a person is taking to make sure that there's no interactions. If on the Liverpool checker, they'll come up as red, amber, or green. So green is that there's no expected interactions, amber is potential, and red is a significant interaction. But with all of them, including some of the red ones, it is worthwhile just reading. There's additional text for each of them, and it is really worthwhile reading that, because sometimes there's very useful information which can allow for administration in certain cases. So a really good example of that is with the statins. So for example, I think simvastatin comes up as red, but if you read through the information, it's clear that it can be given, but you just have to hold the statin for the 5 days of the Paxlovid treatment plus a further 3 days, and that applies to all of the statins. So that's, I suppose, worthwhile just taking the time to read that detail. And sometimes there might just be sort of additional advice that needs to be given to the person. So, it might be just about, watching out for perhaps increased sedation or something like that, which can be managed as maybe a caution rather than a contraindication, but it's just advice that can be given to the patient that can allow this treatment to be used in those really high-risk people, because some of them really are very vulnerable. So if we can use it, it is useful to be able to make use of that clinical expertise that's kind of captured in this resource for the benefit of those people. And then just finally, once all of that's been done, it's just that consideration as to whether they're going to get the full treatment standard course or the reduced renal course. And that's just a kind of a reminder about the need to report any suspected adverse reactions through the HPRA website, particularly given that it's such a new drug and there's not a lot of evidence of its use in real life yet. So it's definitely worthwhile reporting anything, and pharmacists can do so. And then finally, just before we sort of move on to some of the case studies, just a little piece about planning ahead. So we know at the moment that not all patients who might be eligible might even know that they're eligible for these new treatments. And there will be comms coming out from HSC about, raising awareness. And there will also be, I suppose, information going out through, say, patient advocacy groups, where they're, sharing information with their with people who use their services who may be in those vulnerable groups. But it's, I suppose, a couple of things which are useful is, if you do have somebody who is a regular person that comes to your pharmacy and you know that they're definitely in tier 1 or tier 2, it's helpful for them to know that if they do test positive for COVID, I suppose the main message is to contact their GP or their prescriber in the hospital quickly, so that they can benefit from the treatments if they're eligible within that 5-day window, because you don't want them presenting on day 5 or after day 5 when it might be too late to coordinate everything and get the prescription issued. So that raising awareness may be very useful. And if you are doing so, just asking people to make sure they have a list of all of their medicines handy that can be shared with a prescriber, just to, I suppose, save time and to make sure that that prescribing can happen safely. And if people are looking for a way of promoting that, the My Medicines list is available on the safermeds.ie website, and there's plenty of hard copies available from the health promotion website if you want to order a batch. So I think we might move on to some case studies. The first one is Miss A.M. She's 54 with rheumatoid arthritis and no other significant history. She currently is on methotrexate, 10 milligrams once a week, and she takes folic acid 2 days after that, and she's on PRN ibuprofen as well. She had a home antigen test, which was positive yesterday, and she just makes contact with the pharmacy because she's aware that there's some new treatments. She's seen some information in the press, but she's not really sure whether they're available yet or if she would be someone that would be eligible. So I suppose the first question is she somebody who would be eligible? And this is a table taken from the HSE guidance, and it's the treatment-based section. So there's quite a long list of, I suppose, conditions which would mean that you might be eligible for these treatments. And it covers things like, you know, people who've recently finished chemotherapy or radiotherapy and so on, transplant patients and so on. But this is the section which is dealing with treatment-based reasons why you may be eligible. So these are the people who'd be severely immunocompromised. And if you look down through that, the one in red at the top is highlighted in red because that's the most severe, you know, impact on your immune system, which would be rituximab. So if there is ever a situation where there's limited supply in the country and it has to be severely prioritized, then these would be the people who would get it. But that's not the case at the moment. So any of the people who are on this list would be eligible in tier 1 or tier 2. And if we look down through this, we can see that methotrexate on its own isn't mentioned here. It's mentioned if someone is on a second bottom line there, biologic plus azathioprine or a biologic plus methotrexate. But methotrexate on its own doesn't kind of place you in tier 1 or tier 2. So just, oh yeah, and this is another table which is in the HSE guidance, and it just calls out the specific drugs a little bit more clearly. And you can see the first 2 boxes are the same drugs that were on the previous slide, but the third box down there includes methotrexate under the heading, the following therapies do not ordinarily impair vaccine responses, and patients do not automatically fall into tier 1 unless there's clinical or lab evidence of immunodeficiency or a poor antibody response. So methotrexate is listed there under that heading. So on its own, methotrexate isn't enough for someone to be eligible for these treatments. Now, same person, so when you check her medication history, you realize actually she was just recently on a course of steroids. So she had a course of prednisolone 40 milligrams for 10 days, which was then gradually reduced, and finished that course a couple of weeks ago. And she was also on esomeprazole while she was on the prednisolone. So the question now is, does this change her risk? And I suppose if you were paying attention to the tables on the previous couple of pages, you would have noticed that prednisolone treatment it may place somebody in tier 1 or tier 2, and that is dose dependent. And the cutoff point is 40 milligrams a day for a week or more. So in this particular lady's case, she's had 10 days of 40 milligrams. So that would certainly place her into tier 1 by virtue of the prednisolone rather than the methotrexate. So just, I suppose, thinking through the pathway for her, we can check down through the left-hand red box there, and we can see that there aren't any contraindications that we're aware of for her. So we're going to move on and check through her drug interactions. This is the page of the Liverpool checker, and it's a little bit busy, but if you just, I suppose, look halfway down on the left-hand side, there's a box for you to enter the first drug, which is Paxlovid. So you can enter it there. And then into the middle there, you enter any other drugs that the person is on. So when you've entered one, you can go back and start again and enter another one, and it'll save any that are listed below for the same patient. So here we've just entered the methotrexate so far, and we can see on the right-hand side, there's a green box halfway down, which says that it's green and there's no interaction expected with the methotrexate. So the other box to note there, actually, sorry, Mary, if you just go back there, just above that green box, there's an option to switch to table view on the right-hand side, halfway down. And that's just a really handy way. If you've got 4 or 5 or more drugs to check with Paxlovid, it allows them to be all presented together. And that's what I'm going to show you on the next slide. So this is the table view. So we've added all of her medicines, so her esomeprazole, folic acid, ibuprofen, and methotrexate for this lady. And you can see on the right-hand side, there's 4 green diamonds. So for all of those 4 medicines, there's no interaction expected. So for her, we don't have any information to suggest that she needs to have any renal impairment dose adjustment. So it would be a standard dose 5-day course, which is the 2 nirmatrelvir tablets with the 1 ritonavir together, BD for 5 days. And her normal medicines that she usually takes can stay as they are, take them as normal. So Mary, I think, do you want to go through the next case?
Thank you, Muriel. So case 2 is Mrs. PB. She's 78 years old. She has no known medical history and no regular medication. And she has recently arrived from Ukraine with limited English, and she's unvaccinated for COVID. So I think Mrs. PB is a likely type of patient that will be encountered over the coming weeks and months. So Mrs. PB has had COVID symptoms for the last 2 days. She's antigen test positive today. She's been seen by GP and is awaiting a PCR and UNEs. So from what I would have briefly referred to earlier in the interim guidance, I'll show you now on the next slide that Mrs. PB is in fact a candidate for Paxlovid. So she's in tier 1 and she's an unvaccinated adult patient over the age of 75 years old. Okay, and as Muriel would have highlighted, we'll just do a quick check that she's not fitting any of the contraindication criteria, and she's not taking any regular medication. So I guess we're just waiting to see what her renal function comes back as in terms of what dose she would be prescribed. So as I said, she's not taking any other medication prescribed or over the counter, and this was confirmed with a family member that was translated. Her PCR does come back as COVID detected, and her UNEs demonstrate that she has a creatinine clearance of 45 mils per minute. So that does put her in the category for a reduced renal dose. So her reduced dose then, as we would have referred to earlier, is 1 tablet of the nirmatrelvir with 1 tablet of the ritonavir twice daily and for 5 days. And again, just to emphasize that you would be removing 1 of the nirmatrelvir tablets from both the morning and evening blister of each strip. Muriel, I'll hand back over to you to take us through case 3.
Okay, so next up we have Mr. TJ. He's 84 and he's hypertension, hypercholesteremia. His usual medicines are aspirin 75 daily, bisoprolol 5 milligrams daily, ramipril 5 milligrams daily, and atorvastatin 20 milligrams daily. He has had 1 dose of this COVID vaccine, but he didn't feel too well afterwards and decided against returning to get his 2nd dose. So I suppose if you refer back to one of the earlier slides, by that definition, he's not considered to be vaccinated because he hasn't completed his primary course of vaccination. He has had COVID symptoms for the last 3 days, seen by GP and awaiting PCR. His last renal function test 3 months ago was showed a GFR of 70. So I suppose the question is, would he be somebody who would be eligible for Paxlovid? So we checked down through the contraindications. We know that he's over 18, he's not pregnant, he's got good renal function to the best of our knowledge, and we don't know of any severe liver disease. He can take his tablets. So we're going to move on to checking his drug interaction profile. And this is again from the Liverpool checker. So the first one that we're entering here is atorvastatin, and you can see, so that's in the middle column there, and you can see on the right-hand side, it's coming up as amber, so that's a potential interaction. So on this screen, you can click on beside the right-hand side text which says atorvastatin just below that orange box, and that will bring up additional detail. So we'll show you. And this is the table view. So sorry. So this is the table view. So we can see that his other medicines are fine. It's just the atorvastatin that we have a concern about. So if you look into the additional detail on the Liverpool website, this is what will come up. And it tells you that co-administration is not being studied, but that atorvastatin is metabolized by CYP3A4, and concentrations of atorvastatin are expected to increase. And that co-administration is not recommended unless specifically required for patient management. But that given the short duration of Paxlovid, atorvastatin should be stopped. And the pragmatic approach is to stop atorvastatin temporarily, or any other statin. And that's considered to be acceptable, considering it will not negatively affect the therapeutic effect of the statin because it's such a short interval when it's being paused, but that it can minimize the risk of adverse events relating to a drug interaction. So if you're going ahead with using it, atorvastatin can be restarted 3 days after the last dose of Paxlovid. So the recommended action for this particular patient is to hold atorvastatin during the Paxlovid 5-day treatment course and for 3 days after. So that's holding it for 8 days in total. And this person would be eligible for the standard treatment course of Paxlovid and continue with all his other medicines as normal, with no other adjustments needed to them.
Okay, I'll come in on case 4 then. So we have Mr. HF he's 32 years old. He had a renal transplant 9 months ago. And again, just for the purposes of highlighting the case, we have included some potential medications that Mr. HF is on. But again, it's most likely a patient of such would be on certainly a longer list of medications, but so he's on tacrolimus, mycophenolate, cotrimoxazole, lansoprazole, and prednisolone. He's had his 3 doses of COVID vaccine as his primary course, and then 1 booster dose. So he's had COVID symptoms for the last 48 hours, and he's antigen positive at home, seen by the GP, awaiting a PCR, and his last renal function was 35 mils, was a GFR of 35 mils per minute. So is Mr. HF a candidate for Paxlovid? He certainly is, according to the HSE interim guidance, and I suppose from 2 aspects. One, that he's been a recipient of a solid organ transplant within the last year, and also then with the medication he's on, so the tacrolimus, the mycophenolate, and the steroids. Okay, so we checked through to see if there's any other contraindications. So he's 32. We know the recent renal function. He doesn't have severe liver disease, able to take his medication fine. So we'll check through then to see if there are any of his medications that are contraindicated. So using the Liverpool interaction checker, we check we list all the medications here, as you can see in the middle column, and straight away the contraindicated medications will appear on the top of the search results. So we can see that tacrolimus is contraindicated, and Mr. HF would not be a candidate for Paxlovid because of the interaction with tacrolimus. And we'll on the next slide I'll go through a little bit about that. And again, just to say that this is very much consistent with what Patricia Ging would have presented in her recent session, detailing the medication, the COVID medications in transplant patients. So there's a high risk that tacrolimus would reach toxic levels if co-administered with the Paxlovid. So I think this is a very good point in the presentation to highlight. Again, we mentioned earlier that the evidence base for this medication, it's currently just one trial, so it's not a very strong evidence base. So it's very important to call that out, and really that safety is of our utmost concern. So we don't want to put a patient at any risk due to these potential interactions. So it would be safer that Mr. HF did not get Paxlovid in this instance. And there is the option to for his specialist team to review him to see if he is a consideration for any alternative treatments that are available for COVID at this point in time. Again, bearing in mind that this situation can actually change quite quickly in terms of what available medications are. And again, I suppose the most important thing to do would be just to have a check back to the current version of the HSC interim guidance. As I said, it's version 4.1 that's currently available, but again, that can change and sometimes over the matter of a couple of days. So it's very important to be aware of the most up-to-date guidance. And Muriel, over to you for case 5.
Thank you. So case 5 is Mr. JM. He's 54 and he's a shift worker, and he also has rheumatoid arthritis. He gets rituximab IV infusion every 6 months in a hospital setting, having had a dose 4 months ago. And he's also on methotrexate and folic acid. He also sometimes uses Zolpidem PRN for insomnia. His scripts received in the pharmacy from hospital consultant for a standard pack of Paxlovid, so the 300 milligram and 100 milligram taken together, BD for 5 days. And I suppose the question is it safe to proceed with dispensing for this man? So, I suppose we check down through the contraindications, and we are not aware of any from that list. So moving on to check through his drug interactions. It's a little bit faint, so I hope you can make this out. So, so we have the Paxlovid entered on the top left-hand corner with all of his other medicines in the middle there. And you can see that there's an amber warning coming up for Zolpidem. And I've just popped the table view onto the same page, so that's what's down below there. So the table view shows us that, yeah, folic acid and methotrexate are fine, they're in the green category, but Zolpidem is amber. So what does that mean for this man? So in summary for Zolpidem, the recommendation is that it could potentially increase Zolpidem exposure. However, a dose adjustment may not be necessary based on interaction data with ketoconazole. But certainly patients should be informed that they may experience enhanced sedative effects, and that after stopping Paxlovid, the effect should disappear within 3 days. And on checking the SPC, it's kind of similar information that's in the SPC, which says that Zolpidem and ritonavir may be co-administered with careful monitoring for excessive sedative effects. So I suppose it's a caution rather than a contraindication. So I suppose in terms of advice to this particular man, you know, ideally, if he could avoid the Zolpidem while he's on the Paxlovid, if he currently just takes the PRN, that would probably be the best option. But if he is continuing it, he just needs to be advised that he might find that Zolpidem will cause additional sedation while he's on the Paxlovid and for a couple of days after, and just to be cautious about any activities the next morning. And I suppose it's worthwhile just pointing out that Zolpidem is cautioned, but there's some other benzodiazepines and sedatives which are actually contraindicated. So, you know, we haven't gone through all of the meds which are contraindicated in this presentation, but I think this is one that's worth just, you know, drawing your attention to. So diazepam, flurazepam and trazolam are all contraindicated with Paxlovid, and then alprazolam would be cautioned, similarly to Zolpidem. So that's our final case.
Okay, so we've Miss Pate, 62 years old with a past medical history of atrial fibrillation, and she also had breast cancer with completing her chemotherapy 2 months ago. So her current medication is tamoxifen, amiodarone, apixaban, atorvastatin, and perindopril. So Miss Pate is antigen positive at home and has heard about the new COVID treatment and phones your pharmacy asking whether she would be able to take it with her other medications. So in terms of eligibility, she certainly fits the criteria of being a candidate for Paxlovid. So she has an active solid cancer and she's completed her chemotherapy within 3 months. So again, just emphasizing the importance of the checks for each patient. So just checking that she doesn't have any of the contraindications, which she doesn't, but obviously just to check for the medication interactions. So using the drug interaction checker, immediately we can see that there are 2 contraindications. So the first one being amiodarone and the second apixaban. And again, the patient has atrial fibrillation. So with amiodarone, it's not an option to stop or to hold that medication. And again, with apixaban, that is not an option either. So in terms of the specifics of the interaction, so with amiodarone, there's certainly an increased possibility of the increased contraindications, which may ultimately lead to an increased risk of arrhythmias. And in terms of the apixaban, again, there's an increased concentration, obviously with a subsequent increased risk of bleeding. Okay, so that takes us to our summary slides, really, and I suppose we've highlighted these key points throughout the presentation. And Muriel, feel free to pop in as well if you want to add anything further to this. But just to emphasize that really vaccines are our first line of defense in terms of managing and preventing COVID infection, and they're superior to the treatments that are currently available for COVID-19. The evidence base for these novel agents, these trials again were carried out in unvaccinated populations and prior to the emergence of the current circulating strains. So I think, you know, that's very important to bear in mind. And because of the lack of this strong evidence, it is very much a reasonable approach that clinicians may wish not to prescribe these therapies. So just that you're aware, and this is called out within the HSE interim guidance, that this is a valid clinical management strategy. And due to the high prevalence of the interactions, again, it's very important to emphasize how critical it is to take that full drug history and to make sure that all sources have been considered. Again, if the patient is potentially using other community pharmacies or if they're accessing meds via the hospital route and their herbal and OTC medications.
Yeah, and Mary, I might just jump in there if that's okay. So
yeah,
just I've seen quite a few of the queries coming through on the chat box there, and there's quite a lot of kind of points about particular meds. So I suppose the main thing I would really emphasize would be that our case studies have highlighted some of the medicines which are impacted by Paxlovid, but there's a very long list, and we definitely haven't covered all of the ones which are impacted. So, things like anti-epileptics, lots of the medicines which you would expect to have an impact in drug interactions, they do. But there is also drugs like colchicine, which can have a very significant interaction, which isn't one that you would necessarily be, at the top of your list of drugs to have concern about. So I suppose the message is that you really do need to check your sources for each drug that the patient's on, and not just rely on what a lot of us do as pharmacists and say, okay, so it's not one of the kind of very high profile drug interactions drugs that I need to be checking for. You actually need to check for every medicine in this particular case.
Yeah, absolutely.
Muriel and Mary. So there have been quite a few questions coming into the chat, and what I'm going to try and do is take these to the best of my ability according to the same topic or theme. There are a few outliers, so apologies if you feel like your question's not been answered. Perhaps just retype it into the chat if you feel like I've not addressed it after a few minutes of discussing with the presenters. So the first topic that I think has come up is around renal function, whose duty it is to calculate that. How is that calculated? Is that Cockcroft and Gout or another method? And how would we get that information? So maybe some further context around that would be helpful if you have it, please.
Yes, so it's the prescriber's responsibility to prescribe according to the renal function, unless they've specifically asked for, if you're working in community pharmacy, unless they've specifically made contact with you around that, it's expected that the prescriber will prescribe the dose according to the appropriate renal dose. In terms of calculating it, what's in the SPC is the EGFR. So in terms of calculating Cockcroft and Gault, which would be, I suppose, the gold standard for medication in general, that's not necessarily what's in the SPC. So the EGFR, I suppose, is what's reported, I suppose, more automatically on reports that come back to the prescriber. So that's acceptable to use. It is recommended to use Cockcroft and Gault, particularly for older people. So certainly those over 70, I think it's recommended that you would use Cockcroft and Gault, but that's not what's in the SPC. So I think, I suppose the answer really is that it's the prescriber's responsibility to ensure it's the appropriate dosing that's calculated and communicated.
Thank you. There have been some queries put in about what is meant by unvaccinated. I think you have clarified that throughout, but perhaps you could clarify again for anyone who's missed that, please.
So I'll come in on that. So unvaccinated is those that haven't received their primary schedule. So it's irrespective of whether they've had booster doses or not. It's if they haven't had their primary schedule.
Thank you. A question that came in quite early on is in relation to the EPIC study that underpins the evidence for this medication. Do you have any information on what variant that study focused on?
As far as I know, it was the Delta. It was certainly prior to the circulating Omicron.
Thank you. Apologies, I'm just floating down through the questions here. Okay. So any information about the use of this medication in long COVID at the moment?
There's not any trial data that I'm aware of in long COVID, no.
Thank you. Okay, so there's been some very useful chat. If you've not been in the chat as an attendee, highlighting some particular problematic drug interactions. So for patients who are taking anti-epileptics, for example, and the potential interactions with this medication, I think that is useful information to highlight again. There's a question here about the tablets that are kind of, if we're not giving a full dose and we're cutting out tablets, what do we do with those tablets? I'm not sure if it falls outside of the scope of this presentation, but if you have any thoughts on that.
Yeah, well, they're not going to be used for any other purpose, so I think it's appropriate to just to discard them. I think Kate may be there with her hand up there just now. Do you want to come in, Kate?
Thank you.
Okay, in terms of they're for disposal, in terms of they are absolutely for disposal. I've been looking at the chat, and this will be provided to pharmacies when they have a prescription at 0 ingredient cost. We expect to be providing a circular very shortly, and the responsibilities for the pharmacist are twofold. One, the final checks and balances around the drug interactions, and two, the final check that the product has been provided within 5 days of symptom onset. So renal clearance, all those aspects should have been dealt with at a much earlier stage. But the responsibility for the pharmacist is where their expertise comes in, that final checks and balances for the drug interaction profile, and then is it in time for the antivirals to actually be effective?
Thanks, Kate.
Thank you, Kate. I think I've gotten the general breadth of the questions, but please do, if you feel like I haven't addressed your question, please do highlight that to me.
And Mary Claire, if I could just come in on a point there raised by Kate that I suppose we'd included in the presentation, but we mightn't have put sufficient emphasis, is that early treatment piece. So obviously these medications are more effective the earlier they are started. So there is that 5-day cutoff, but obviously as early in the onset of symptoms, the better.
Okay, thank you. A question, and there has been a previous question on reimbursement. Kate, I'm not sure if you want to take that one. Thank you.
No, that's no problem. I mean, what we have done in preparation for the rollout of Paxlovid in community dispensing is to put the system in place as if it was a high-tech medicine, in the context that it would be provided at no cost. There are still some administrative pieces to be finalized, but the key thing is there will be a bespoke ordering process with United Drug. The idea is the pharmacist requisitions the product and separately provides a copy of the prescription and the order form to the HSE through pharmacy.response. And in all of the communications, and the circular will provide copies of other communications to GPs. All the communications is that when the patient presents, or rather when the patient consults with the GP, that they at that stage start to consider whether the patient is suitable through their medication profile. So that is to try and ensure that the 5-day window is met. There will be no cost to the pharmacy, but we do expect the pharmacy to counsel the patient's agent or the patient by phone. And as Muriel and Mary have set out, there is a significant element of checking against the medication profile.
Thank you, Kate. There's a question here about some doses, combined doses or mixed vaccine regimen. So I'll read out the question. Janssen single dose vaccine, is it considered a primary course, or if a patient had a follow-up with one Pfizer vaccine after Janssen, is this considered to be fully vaccinated?
Mary, I don't know if you have any thoughts on that. My understanding is that in terms of the Irish setting, we still consider somebody to be having had their full primary course with one Janssen dose. Having said that, most people who would be eligible are likely to have been in the immunocompromised group and would have had Pfizer. But it might be something we need to just confirm.
Yeah.
Okay, we're happy to put additional questions or confirmation comments in the footnotes for this webinar when we post the recording, if that's okay. There's a question come through about if a patient is hospitalized and is not on oxygen, but then is put on oxygen by the time the drug reaches the ward, can they still give the drug?
So Paxlovid should be started in, there's the indication there for somebody who's eligible to be commenced on Paxlovid, and they shouldn't be on oxygen at that point in time. But if they are subsequently, if they do go into hospital, or if they're in hospital and their treatment is escalated, they should continue the course, but they shouldn't, and complete the 5 days, but they shouldn't start it if they're at that higher level of needing care.
Thank you.
And on that piece as well, if a patient is started in hospital on the Paxlovid, the full box should be sent home with the patient for them to complete their course if it is that they're discharged before the course is complete.
Thank you. There's an observation here about how comprehensive the Liverpool Interaction Checker is, and to check sources elsewhere. Would you agree with that comment, Muriel and Mary, in terms of
I think it's always good practice with any drug interaction checks not to rely on a single source. It is a very good resource, and that with the SBC, I think is a very reasonable combination of checks to have in place. I think it's unreasonable to go too far beyond that unless you have specific concerns.
We have a few questions coming in about ordering processes, suppliers, etc. I will read them out. Yeah, thank you, Kate.
I can deal with that.
Yeah, so ordering for a hospital or community?
There's two pathways. One, the sotrovimab ordering process is being slightly adjusted for access for Paxlovid for inpatients. As Mary has said, the patient who is initiated in the hospital setting as an inpatient will get it through that hospital ordering system and should take that home. For the community, it's a bespoke order form. It will accompany the circular. It will be a 7-day service. It will be a weekend service by initiation by the pharmacy. And so therefore, the concerns that might arise around not getting Saturday deliveries have been considered and dealt with. I do expect the circular to be imminently disseminated, but we are entering into a bank holiday weekend. So again, there are arrangements in place to deal with that. So 2 separate systems, one for hospitals, one for community. You order one day and it comes the next day. And that resonates with what Muriel was saying, to give sufficient time for the pharmacist to do the final checks and balances. But in every single document that will go to GPs, it will ask them to early liaise with their community pharmacy, because quite simply, the decision may well have been made by the potential prescriber that by the time the PCR comes back, they will have made the decision that the patient is not suitable and requires further onward referral into the hospital consultant. So early consideration, do the checks and balances. The prescriber has a responsibility for the renal clearance, and it's a bespoke ordering system that has one pathway to United Drug. Order one day, deliver the next day, and a copy to pharmacy.response with a copy of the order form for the stewardship that we want to put in place for this particular product that has some evidence, but for some patients, it will make a difference.
Thanks, Kate. I think you've confirmed it in your comments there, but just to confirm that this is available through UD.
It's United Drug, it's UDD, it's bespoke order form, bespoke arrangements, and weekend and bank holiday arrangements as well.
Lovely. The questions have slowed down. There's one final one here about previous exposure to COVID. Is that viewed as the same as being fully vaccinated?
It's not part of the decision making in terms of whether someone is eligible or not. So it's not considered to be part of the reasons why you may or may not prescribe. I don't know if that's clear. So if someone has had a recent infection and they're positive again, is that the question? They would still be eligible. Yeah, it's not that the recent infection doesn't count towards any kind of vaccination status.
Okay, thank you. When will the bespoke order forms be available in community pharmacy? Kate, I'm not sure if you have any information on that precisely at the moment. You're muted, but I think so you're saying no, you don't have any particular information at the moment. Sorry.
Sorry, in terms of, how would I put it? This is this is a drug that doesn't fit easily into our existing arrangements. So we're awaiting clearance from the department in terms of the fee that would be paid to pharmacists for the dispensing service. When we have that, we will issue the circular and the order form will accompany the circular.
Thank you, Kate.
And we do expect that quite quickly. We do expect that quite quickly.
Somebody wants to revisit the question around oxygen, and I'm not sure if we want to do it outside of here. I'm happy to take steer from the presenters, but I'll read the question in any event. If a patient's at risk of progressing to severe COVID-19, then surely the drug, if it takes a day to come in and they're progressing onto oxygen, these patients are clearly unwell. So I suppose it's about their eligibility to start the drug, and it's taking a day to come in and they might be progressing onto oxygen. Is that a fair representation of the question?
I think these are certainly, and I guess guidance can only cover kind of the majority of potential scenarios. So I think situations like this are very much individual and need to be considered locally. And again, if they're in hospitals, it may be that there may be, depending on the exact supply arrangements that need to be ironed out, but it may be that there might be some supply within the hospitals. So I think we can't give a definite answer either way on such scenarios, but just, I suppose, to bear in mind those particular factors.
I mean, I think the people in hospital who are most likely to be candidates for Paxlovid are probably people who are there in hospital for other reasons, who happen to test positive for COVID. Because if someone is, unwell enough to be admitted to hospital with COVID-19, they're more than likely going to be started on oxygen, and in that case, they wouldn't necessarily be candidates. But if they are, we have certainly, there's people in hospital who are admitted for other reasons who do happen to test positive while they're there. They may be candidates. And I suppose the other thing, which I don't think we've really emphasised all that much in the webinar, is that there will be an amount of prescribing will come from secondary care to community pharmacies as well. It won't just be the GP pathway. So I think that's worth just calling out as well.
Thank you very much. The questions have slowed down. I appreciate there might be outstanding questions. If we feel we get questions in that maybe haven't been addressed in the content of the webinar this evening, we might put them to our presenters and add them as footnotes after the event. But I do feel like a large amount of information has been provided there, and hopefully you found that helpful. Audrey has kindly posted the feedback survey into the chat function, so we would be very grateful if you could complete that.
Mary Claire, sorry, there is a little
Audrey.
added question in the survey that anything they did want to ask. So there is a spot in the survey that they can ask if they feel there was anything that wasn't answered tonight.
That's really helpful. Thank you, Audrey. So I suppose just to close off the webinar, thank you very much to Mari and to Muriel and to Kate there for taking questions. That was really comprehensive and I found it very helpful. Audrey, if you wouldn't mind just pulling up our concluding slides before we sign off. Thank you. They're coming up slowly. So as we mentioned, the feedback survey has gone into the chat, and we would welcome your comments and any additional questions that you might have if you have a burning question. As always, we would encourage you to consider what you've learned here this evening in light of the 5-step reflection model and record that in your e-portfolio when you get a moment. With regard to future webinars, we're going to take a little break over the Easter, and we will return on the 4th of May, which is a Wednesday at 8 p.m. and we'll be looking at care of patients on cancer treatment in the community. You will see that advertised via email, through Twitter, through LinkedIn, etc. And you can sign up to attend that. And again, that will be recorded and hopefully be an informative webinar for you. So thank you very much. I appreciate we've gone over time, and I'm very grateful to the speakers for taking all those questions. It's been a very busy webinar this evening, and I think everyone has found it very helpful. Thank you very much.